One of the green testifier sheets that are on the table at the back of the room. Are they actually there? I think I see something green there. Be sure to print clearly and fill it out completely. Please move to the front row. You don't have to do that because, well, it's just us today. When it's your turn to come forward, give the testifier sheet to the page. There isn't one. So Barb, will you serve as page? Absolutely. Thank you. If you do not wish to testify but would like to indicate your position on a bill, there are also yellow sign-in sheets in the back. We'll skip that since I think almost everyone here is going to be testifying. She's shaking her head no. When you come up to testify, please speak clearly into the mic. Tell us your name, spell your first and last name to ensure we get an accurate record. We'll begin each hearing, that would be this one, with the introducer's opening statement, followed by proponents and opponents, and finally anyone in the neutral capacity. We'll finish with a closing statement by the introducer if they wish to give one. In this case, we're just doing an 11:15 hearing. We're going to be using a 3-minute light system. Don't worry, if you have more to say, we'll encourage you to speak for a really long time, okay? When you begin your testimony, the light on the table will be green. When the yellow light comes on, you have a minute remaining. The red light indicates you need to wrap up your final thought and stop. Questions from the committee may follow, which do not count against your time. Please give us 12 copies of what you have to share. Props, charts, and other visual aids cannot be used simply because they cannot be transcribed. Please turn off your cell phones. Verbal outbursts or applause are not permitted in the hearing room. Such behavior may be cause to ask you to have to leave the hearing, and that's when Barb picks you up by the scruff of the neck and takes you out of here. Finally, committee procedures for all committees state that written position comments on a bill to be included in the record must be submitted by 8 a.m. of the day of the hearing. The only acceptable method of submission is via the legislature's website at nebraskalegislature.gov. Written position letters will be included in the official hearing record, but only those testifying in person before the committee will be included on the committee statement. Sorry, that's all that fun stuff you have to read, like the really fast stuff at the end of a Tier 4 medicine on TV where you have no idea what that drug is for. I will now have the committee members with us today introduce themselves, starting with Senator Reapy.
I'm Merv Reapy. I represent District 12, which is Omaha, Millard, and the small town of Ralston.
I'm John Frederickson. I represent District 20, which is in central west Omaha.
Dan Quick, District 35, Grand Island.
Bow Valley, District 21 in Northwest Lincoln, Northern Lancaster County.
Also assisting the committee today, to my left is our research analyst, Bryson Bartels, and to my far left is our committee clerk, Barb Dorn. And pursuant to Nebraska Revised Statutes, Section 81-604, the Department of Health and Human Services is required to notify the chairperson and members of the HHS committee prior to submitting a demonstration project waiver under Section 1115 of the Social Security Act to CMS. Subsequently, the Health and Human Services Committee is required to hold a public hearing on such waiver application during the period for public comment. Today's hearing is for an 1115 waiver on substance abuse or substance use disorders. With that, we will open with the department to explain more about this waiver. And with that, we are ready, sir. Would you please introduce yourself and spell your name for us?
Yes,
and maybe spell your last name 2 times just to make sure we get it.
Okay. Well, thank you for having me back too. I hope everybody's summer's going well so far. But good morning, Chairman Hardin and the members of the Health and Human Services Committee. My name is Drew Gonczarowski, DREWGONSHOROWSKI, and as requested, the last name is GONSHOROWSKI. And I am the Director of the Division of Medicaid and Long-Term Care in the Department of Health and Human Services. Today's hearing is required by Nebraska Revised Statute, Section 81-604, as part of our duty to inform the legislature about our intent to submit an 1115 demonstration waiver amendment to the Center for Medicare and Medicaid Services. Nebraska Medicaid is currently in the process of amending our 1115 demonstration waiver for substance use disorder services. As part of this amendment, we are requesting authority from CMS to provide 2 additional services. These services will be available for anyone with full coverage Medicaid benefits. The first service will allow us to treat individuals with serious mental illness or serious emotional disturbance for a short-term stay in an institute for mental disease. This authority will allow Nebraska Medicaid to cover treatment for people undergoing a crisis in a psychiatric hospital for up to 60 days. We anticipate that providing this service will allow people undergoing a crisis to receive prompt, quality care in an appropriate setting. We expect that providing this service will reduce readmissions to emergency rooms and residential care facilities, improve access to services, and better coordinate care along a continuum for those with mental health challenges. The second service we are requesting is to allow Medicaid payment for medical respite services. Pursuant to Nebraska Revised Statute Section 68911, we plan to have 2 medical respite facilities, one in Lincoln and one in Omaha. These facilities will offer a place for the homeless population to receive care after they discharge from a medical facility. The respite facilities will offer a stable, safe environment for people to get follow-up care and complete the healing process. We anticipate that providing a safe place for extended care will prevent hospital readmissions and improve health outcomes for this population, reducing future Medicaid expenditures. We are currently in a public comment period. After the public comment period ends, we plan to submit the 1115 demonstration waiver to CMS for approval. The anticipated effective date for SMI SED stays in an IMD is January 1st, 2026, and the anticipated effective date for medical respite is April 1st, 2026. Thank you for your time. I would be happy to answer any questions related to this hearing and this waiver amendment submission.
Thank you. Questions? Senator Frederickson.
Thank you, Gerhard. Thank you for being here, Director, and for sharing your testimony today. So first of all, I think this is I certainly think this is a good idea to apply for this waiver. I'm glad to see the department is taking steps in this action. I did have a couple of questions, though, as I was reading this and obviously kind of thinking about this kind of in the larger context of the recently passed federal legislation, specifically as that relates to Medicaid funding. I know some of the language in HR 1, for example, talks about Medicaid waiver, 1115 waivers having the requirement of budget neutrality by a certain date. And I just wanted to kind of hear what the department's thinking about long-term sustainability of this waiver, what implications that bill has on sort of how the state will navigate this.
Really appreciate that question. It's a question I think all of us across government are trying to address in terms of changes that are coming in HR 1 and also effectively ensuring the sustainability of our Medicaid program. This 1115 waiver, as part of a requirement for 1115 waivers, they have to meet budget neutrality. So the anticipation is that any waiver effectively it remains budget neutral for the duration of the waiver. So Medicaid has a specific requirement to manage any sort of waiver under that, I guess, requirement. With that, within this amendment, I believe in June, CMS also extended our SUD waiver, the 1115 waiver for the next 5 years to 2030. There's sort of similar budget neutrality calculations. This is an amendment within that waiver. I don't necessarily think that there is a risk, a long-term risk in terms of being able to maintain this waiver through the demonstration period.
Okay, so you don't anticipate this will impact the state budget?
I don't anticipate it.
Okay.
And if it were to, it would not meet the requirements of maintaining the waiver.
Okay. And then my other question, just kind of given the specific population that this waiver would be geared towards or to serve, obviously folks with substance abuse challenges or behavioral health related issues. These are folks that, as you're probably aware, kind of depending on their condition, treatment wise, might be inpatient for a period of time, might be outpatient treatment, kind of depending on where they are in their process. And kind of going back to this idea of HR 1, I know that one of the requirements in that bill, for example, are new work requirements for folks that are on Medicaid, especially particularly Medicaid expansion impacted folks. Considering that with this population that would be served under this waiver, how would that relate, or how do we anticipate? Would there be an exception for folks who might be inpatient, or how do you look?
Yeah, so in terms of the provisions that would impact expansion population is probably what you're referring to in HR1. It's sort of the work requirement and some of the redeterminations of eligibility. There are outlined exclusions. It is my view, and I think the division's view, that folks with SUD or SMI would fall in those exclusions for those work requirements, so we wouldn't expect that they would be impacted. But it is sort of on the division to make sure that we are appropriately capturing folks that are excluded under those provisions that are coming.
Sure. And I know that this is all new, obviously, and I imagine the department's kind of waiting further federal guidance on kind of what this all looks like as it rolls out. Has the department been sort of informed of any specific guidance on this?
That's a really great question. Reading the legislation, you'll note that the guidance deadline is pretty short compared to the January 1st or the December 31st, 26 implementation date for work requirements take, for example. The expectation is CMS will start reaching out with communication. They haven't just yet. I think they're also sort of figuring out how to operationalize and implement this legislation. So we're in active communication trying to start getting guidance, but it is, to your point, still very early.
Okay. So at this point, no formal guidance?
Yeah, no formal guidance yet.
Okay. Awesome. One more question, then I'll let other folks ask if they have. But one other question I had as it relates to HR1 is, I know that there's a requirement to establish copays on certain Medicaid-related services. I know we in the state have kind of gone back and forth with that. Our MCOs have expressed that that's been more of a challenge than a benefit in some cases. Do you know, and I'm not aware of this, do you know if the 1115 waivers, so for example, populations impacted by this, would they be subject to those copays as well?
My expectation would be that they wouldn't be subject to those copays. However, this is another area where we're waiting for specific guidance from CMS on how even the copays, the sort of expectation in terms of implementation on how they can be applied.
Okay, great. Thank you.
Senator Quick.
Yeah, thank you, Chairman Harden. My question is on the, so you talk about having two facilities for respite, one in Lincoln and one in Omaha. Are those like facilities that are currently there, or is it?
So the facility in Omaha is already identified. It's Sienna Francis House. We're working with partners here to direct resources. So we're trying to identify a good location in Lincoln still.
Okay. And one other question on that is, you know, of course, for rural Nebraska, we still have those issues, the same as Lincoln and Omaha, maybe just not on the same, but would there be maybe thoughts in the future of having someplace in maybe Grand Island or central Nebraska where people wouldn't have to go clear to Lincoln and Omaha for?
Yeah, I could see that as a possibility. It's ultimately the scope of this demonstration, and I believe it was Senator Reepe's bill LB 905 that brought this in 2024 was sort of what we are proposing for amendment today. So it's a smaller demonstration waiver, but.
All right, thank you.
Senator Repe.
Thank you, John. Thank you for being here, and thanks for the work that you do. Along with on the homeless respite care, the ones in Omaha and Lincoln, the Nebraska Hospital Association Foundation has pledged financial support. And I know with some of the reductions coming in their direction, do we still feel that their commitment is sound? And does that have any impact on the waivers as itself?
So I would be hopeful that they would keep their commitment. Just a little context on this. Over the past month, I guess it was just before the 4th of July, CMS did approve the hospital state directed payment that was brought by Jacobson in LB 1087. That represents $1 billion into the hospital systems. That amount of money doesn't get reduced under HR1 for the first 2 years of the provision. And it's money that Nebraska hospitals have never seen prior to now. So the hope is even when that is reduced through the provisions in HR1, it is still a higher level than they were previously. And I would hope that it doesn't necessarily impact that commitment here.
Okay. Second question would be is on the mental health side of this, one of my concerns gets to be is it seems mental health delivery to me is very fragmented. There's little mama, papa, Rosie kinds of shops. Does this fit into the plan? I mean, or does this help consolidate or correct or something like that?
Yeah, I think that's a really great question, and I'll try to do the really great work that Dr. Janicek does over in the Division of Behavioral Health some justice here. But this does fit into sort of the holistic vision that you want to be able to meet people in a acute setting and be able to direct them to other points of care. In terms of the respite setting, the respite care that is in this waiver, it's a great example of that, right? So it's someone that might have had an acute hospital stay, needs some extra time to recoup, instead of sending them out without sort of a place that they can recover safely. That's effectively what the goal is here, is to make sure that they can recover, and then also direct them to other resources that are already available in the state in that setting.
I know with the hospitals, the cost of keeping them in the hospital, $2,000 a day versus being able to put them in a respite center at maybe $250 a day was significant enough to make the hospital association step up and commit.
Yeah, exactly. And that respite setting should also prevent a readmission that would be, detrimental to the member, but also costly.
And costly to the hospital.
Yeah.
Even the hospitals in Grand Island.
Mhm.
Yeah. Well, thank you, Mr. Chairman.
What I'm looking at right now is not something that you handed out for us today, but just because we were doing some digging. The Department of Health and Human Services draft of the 1115 demonstration amendment is what I'm looking at. And I don't know that you have that in front of you. It's just a big picture question, I guess.
Yeah.
And what it states in section 3.4.1, SMI, SED stays in institutions for mental disease enrollment. What it shows after that is in fiscal year 26, we anticipate there could be 504 enrollment by member months. So there could be 504. The next year shows 1,025. A little more than double what happens in the first year. Is there a top to that? Do we anticipate what those numbers might look like in 2028 and beyond? Granted, these are, I think they kind of look at them in 3-year periods. Is that right?
Yeah, that's a good question. I don't have that number
Okay,
in front
I
of me
was just curious
immediately,
how it
but
more than doubled and then what it might look like in
yeah.
how many of these interventions might we have is, I guess.
Yeah,
what I'm
and
questioning.
that's a great question. I can
Okay.
get back to you on that.
All right, very well.
And I'll say too, I think it seems like, because I think the number was 1024 in terms of member months. So
Yes.
roughly around 100 members sort of in the
A month.
in that first period.
I see.
And my expectation is that the sort of ramp up was a question of getting take up or getting people to start utilizing the service or program. But it's a great question, and I'll take it back to the team on what the sort of growth expectation is after those 2 years.
Okay. Senator Ballard.
Thank you, Chair. Thank you for being here, Director. Kind of back to Senator Reepe's question about the plan. In the document you sent out, the goals of utilizing the length of stay in EDs and hospitals while awaiting medical for specialized settings. Can you give us a snapshot of, I know beds are at a premium for some of these facilities. How does this fit into the plan of, is there a process to ensure that these individuals are getting into these specialized facilities and making sure that there's open beds in these facilities as well?
Yeah, so that's a really great question, and ultimately, I'm not sure if there is a specific process here. I think the expectation is in terms of referrals from other settings, but I would have to go back and look for it on specifics there.
Yeah, and then my next question, if I may. So how do you? I mean, DHHS and the legislature has an interest in making sure that these individuals don't come back into the hospital setting for these. So what's the kind of the plan of DHHS's role with providers to ensure that these individuals are staying?
Yeah, so Dr. Janicek works very closely across our behavioral health networks, and it is ultimately making sure that when the person is in a high intensity setting, as they are moving to transition out of that setting, they have specific options in front of them. It's what Medicaid services are available for that population. These waivers do cover people with full Medicaid benefit, so that it is sort of built into this that when they're in that setting, they'll be, to quote Dr. Janicek, wrapped in services or at least presented with the wide array of behavioral health services that are available in the state.
Yeah, I know that's part of the care coordination plan.
Yeah,
that
the
you
care
guys talk about a
coordination.
lot. Okay, absolutely. Well, thank you so much.
Yeah, no problem.
Have we seen these numbers or anticipated numbers change since COVID?
In terms of, I would say, I don't have the specifics on that. My expectation is that it has increased since COVID. And in terms of the SUD waiver, just more broadly, the numbers have increased in the past 5 years.
Okay.
And just sort of for reference on this, the SUD waiver effectively served people with these short-term stays to the tune over the waiver period. I think it was slightly over 6,000 people that Medicaid wouldn't have been able to cover them prior to the waiver. So it's very clear, and I think CMS understood that the past 5 years have been successful on that waiver and why they extended the waiver. But it really is, there is a unmet need that these kinds of waivers do serve.
Very well. Senator Frederick.
Thank you, Chair. These line of questions got me thinking a bit more about this, and specifically kind of Senator Reapy and Senator Ballard's questions as well. One of the things I'm thinking about kind of is sort of this idea of continuity of care, and obviously we're talking specifically about folks who are with acute needs, but it is certainly in the interest of the state and in the interest of Nebraskans to ensure that people have continuing care. I know the governor has recently come out expressing a desire to further cut the state budget by $500 million in addition to some of these larger things. I'm curious to think about what, if any, what impact, if any, do we expect that to have on DHHS and our ability to perhaps continue to provide support to individuals to ensure that they aren't sort of, for lack of a better word, recidivating back into or relapsing back into these issues.
No, and I think that is a really great question given our current times. HR1 with also sort of our budgetary pressures at the state level. And I would think that it means that the divisions across DHHS should be charged to looking for solutions such as these. It's about thinking creatively with the resources that you have, having targeted interventions and programs that come in that specifically serve to facilitate continuity of care, but also prevent sort of costly services being provided, in terms of setting, right? So the respite bill, as Senator Reapy really nicely described, is all about making sure that someone is in the appropriate setting and doesn't re-enter a setting if we can prevent that. And I really do think that's sort of the unifying factor across DHHS. It's ensuring that people are receiving timely and appropriate care and quality care. I think that alignment still can fit under any sort of uncertainty around the federal legislation or otherwise.
Okay.
Other questions? Seeing none, thank you.
Thank you.
Proponents for the 11-15 waiver. Opponents, 11-15 waiver. Anyone in the neutral for the 11-15 waiver? Seeing none of those, this concludes our hearing for the day. Thank you, everyone.